Okay, we're going to look here at some of the orthopedic disorders of the ankle and foot, and we'll do a quick anatomy review. We'll talk about the malleolar fracture, the rupture of the Achilles tendon, and then we'll also briefly talk about the fracture of the calcaneus, which I only think you need to know in a really superficial detail. And then we'll talk about two of the major disorders of the foot that you commonly see in clinical practice, which are Plantar Fasciitis and Morton's Neuroma. So just as an anatomy review, we've got the two bones of the leg, tibia and the fibula being lateral, tibia being medial. They articulate with one another, and then they also articulate with the with the talus. The talus would be your most superior tarsal bone. The talus articulates with the calcaneus, which is the most inferior, and it's also your heel. And the talus also articulates with the navicular bone, which is sort of this tarsal bone that's all in the middle of everything. The navicular bone articulates with your four anterior-most tarsal bones, and those would be the cuboid, which is lateral, and three cuneiform bones. The three cuneiform bones are named medial, which is the one that's most medial, middle, which is the one that's in the middle between the other two, and lateral, which is the most lateral cuneiform bone. And then these articulate with the metatarsals, which articulate with the proximal phalanges, which then articulate with the distal phalanges. And I guess also important to point out that on the tibia is your medial malleolus, and on the fibula is your lateral malleolus. And the malleolus is, I'm not sure how it's anatomically defined, but it's roughly 2 inches. The distal 2 inches, 2 inches, something like that. Okay, and then the Achilles tendon, this is probably your most prominent tendon in your body, and the Achilles tendon is the common tendon of actually 4 muscles, but 3 that are anatomically important. They're the 2 heads of the gastrocnemius, which is really 2 muscles. You got your medial head and your lateral head. The gastrocnemius is superficial, and then deep to the gastrocnemius is the soleus. And like I said, their tendon is common. So all of their tendons combine and attach at the posterior part of the calcaneus. Okay, malleolar fracture. So the malleolar fracture tends to occur due to a sudden twisting, rotating, or rolling of the ankle, and that can either be from a standing position or from walking or running position. It can also happen from trips or falls, and like any fracture, it can happen due to high energy trauma. The important thing here to differentiate out, and this is going to be a theme with the entire physical exam, diagnosis, and ultimately the treatment, the important thing is to differentiate a malleolar fracture from an ankle sprain, from a sprain of one of the ligaments of the ankle. There are a lot of ligaments in that area, and so a lot of motions can cause an ankle sprain. And only 15% of ankle injuries are actually fractures, so it's more likely in more cases than not, when you have a patient with acute ankle pain after some kind of history of injury, that you actually have a patient with an ankle sprain rather than a malleolar fracture. However, there are some things, both with the symptoms and with the physical exam, that can help you determine if it's a malleolar fracture and hence if it needs an x-ray, rather than if it's an ankle sprain and doesn't need an x-ray. So the symptoms of malleolar fracture are somewhat similar to what you'd have in an ankle sprain, in that you'd have immediate and severe pain associated with the incident. You can see some swelling and bruising, and an inability to ambulate. Now, in malleolar fractures, a lot of times it's going to be a flat-out inability to ambulate. But you can't take that inability to ambulate too far, because some patients with malleolar fractures can put a little bit of stress onto their leg, and so they can ambulate a little bit. And some patients with ankle sprains are just such, I hate to say this, but such wussies that they refuse to ambulate at all. And the understandable population where you would see that would be in children. Children, if they get ankle sprains, will not want to walk at all. And so it can be a little bit more difficult in children to use that inability to ambulate as a differentiating factor. So what are some of the things that we see on physical exam? This is going to help you more with your differential. So some of the things that point out to us as malleolar fracture would be, of course, first and foremost, a deformity. So if you've got some strangely held ankle or crookedness or even an open fracture, that's definitely a malleolar fracture. Perimalleolar swelling tends to be because of a bone break, a fracture, so that's another thing that is more likely to be a fracture rather than a sprain. The tendons of the foot and of the ankle are a lot deeper inside the leg and the foot than the actual bone, of course. So if you have swelling, more than likely it's due to a fracture. So deformity and swelling. Bruising and point tenderness, maybe, but that might be sprain too. What I really want you to point towards in your physical, to point to malleolar fracture rather than sprain, is the deformity and the perimalleolar swelling. These two are much more specific towards the fracture. It's going to be important while you're doing your physical exam that you're doing a neurovascular assessment of the affected ankle and foot. So you're going to want to look for the appearance of the foot, make sure that it appears normal, that it's getting vasculature supply, and that you also have a good quality of your pulses. The two arteries that you're really going to be checking for are the posterior tibial artery, which would be just posterior to your medial malleolus, the eminence that you would see anatomically, and then the dorsalis pedis artery, which would be the artery that you can palpate on the dorsum of the foot. And then, of course, you're checking for sensation as well. So those two together will help you assess your neurovascular status, which is really important in ruling out compartment syndrome. But of course, with compartment syndrome, other things that we can see are sort of a dusky extremity, some firmness of the muscles, although that might be a little bit more difficult with the foot because you have so many bones down there. So rule out compartment syndrome. That's going to be important with your physical examination. And not just for the initial physical, but until definitive treatment has taken place. The best initial diagnostic step for malleolar fracture is, like any fracture, an x-ray, and you're going to want to get multiple views here, so at least an AP view and a lateral view. And reduction, as far as treatment, reduction is going to be the treatment, be it closed or open. However, you should not do the reduction unless you're an orthopedic surgeon, which I assume you're not if you're taking USMLE Step 2 or 3. Reduction should only be done by the orthopedic surgeon. The only exception to that is if the patient does have neurovascular compromise. Only in that case should a general physician, even a general surgeon, attempt a reduction. So definitive therapy is going to depend on multiple factors. That's going to be determined by the orthopedic surgeon. As far as therapy, the only time you do reduction is if there's neurovascular compromise. Otherwise, wait for the orthopedic surgeon. Mostly what we're looking for is compartment syndrome. So here's a normal ankle x-ray. And so just to point out some of that anatomy here, of course, here's the tibia and the fibula. Fibula giving your your lateral malleolus, the tibia giving you your medial malleolus. They both come together and articulate. And something important two things important to point out are that your fibula and your tibia both articulate with the talus. Here's your talus here. It's kind of hard to see the distal margin, but here you can see your proximal margin of the talus. And then the tibia has this nice concentric relation with the talus. And when we're looking at dislocations, which commonly occur in malleolar fractures, this will be disrupted. So you'll have the tibia will be dislocated from the talus. Okay. So here's a malleolar fracture of the left leg, and you can see the fracture right here. We have no abnormalities of the fibula nor of the talus. Here's another malleolar fracture. This would be a lateral malleolar fracture. This is in the left leg. So here you see it right here. Here's a bimalleolar fracture, so it's a fracture on both malleoli. And remember what I told you, that the malleoli are not just the very, very, very distal point, but they're roughly like 1 or 2 inches of the distal most point of the tibia and fibula. So this is, even though this is what may appear to be a spiral fracture of the fibular shaft, this is actually a malleolar fracture. It is a spiral fracture, but this is actually a malleolar fracture. And one thing that's good to point out, that it's a spiral fracture, is that what is the common way to get a malleolar fracture? Twisting, rotating, or rolling of the ankle. So those motions would cause a spiral fracture. And then also here, here, of course, is your tibial fracture, your medial malleolar fracture. And you can see here that this is your talus right here. There's that sort of circular portion of the talus, and the tibia is dislocated anteriorly. So you also have a dislocation, and that's very common in the more severe malleolar fractures. So this distal part of the tibia should be back here. Okay. And then this is another fracture. This is a really, 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 really tiny one, but this is another fracture of the lateral malleolus. Okay, Achilles tendon rupture. So remember that the Achilles tendon is a common tendon of the gastrocnemius and the soleus, and those are 3 muscles that come together. So the gastrocnemius is 2 muscles, the medial head and the lateral head, and the soleus is 1 muscle, which is deep to the gastrocnemius. They come together, there's 3 of them. And whenever we think of 3 muscles together that do the same thing, we think of triceps, and actually the Latin word for this muscle complex, the gastrocnemius and soleus, is triceps surae, which means triceps of the calf. So the history, what do we see with an Achilles tendon rupture? Well, first off, you can imagine what it is. It's a rupture of that tendon. But in history, the patients will often be able to relate to you this sudden snap in their lower calf, and it's usually done with some kind of activity. Not your daily activities, probably something, some kind of exercise or going up or down the stairs really fast. And it's usually caused by a strong dorsal flexion. And the patients we tend to see this in, it can happen in athletes, but it tends to happen in people that are less acclimated to the activities that they're engaging in. So think about it along the same lines as who you would see a muscle pull in. Somebody that, maybe a muscle pull you might see in somebody that's moving big boxes of stuff when they're moving out of their house, or moving furniture, not used to doing that kind of activity. What else would you see in somebody that's not used to activity? You see stress fractures. That may be somebody who's running, taking on a new activity. Same thing with Achilles tendon rupture. It's kind of in that class of injuries that are in patients that are overexerting themselves. So it could happen in a poorly conditioned or older patient, but it could also happen in an athlete who is overexerting. A previous history of rupture is very common with patients with Achilles tendon rupture, and the reason for that is pretty straightforward. When you rupture your Achilles tendon and then it heals, the area where it heals is not as strong as the rest of the tendon, and so that area can get ruptured again. Another thing that on the USMLE you frequently see, and it's really, really, really good to know, just for trivia purposes, you may have attendings that come at you and might ask you this. Fluoroquinolone use is something that can contribute to an increased risk of Achilles tendon rupture, or any tendon rupture for that matter. So fluoroquinolone use, which would be like ciprofloxacin and so forth. So, like I said, this is a patient will usually relate a snap audible or palpable in the lower calf, which is then followed by acute pain and then difficulty with plantar flexion of the foot. And that makes sense. What are the muscles in the posterior compartment of the leg responsible for that have their tendons at the Achilles tendon? The gastrocnemius and the soleus. What do? They're responsible for plantar flexion. So if you don't, even though the muscles can work, if you don't have the tendon that attaches those muscles to the bones that they're supposed to operate, then you're not going to be, it's as good as if those muscles were paralyzed. So you can't plantar flex your foot, or it'll be difficult to plantar flex your foot. So these patients are going to tend to hold their this is going to make it difficult to walk, first of all, and these patients are also going to hold their foot in resting position in a dorsal flexed position because they can't plantar flex their foot. So you tend to see them holding their feet in this position. So what you're having your patient do here is just laying on the exam table face down, and then with their legs held up off the table, just in a resting, relaxed position. And you can see the normal leg here, the right leg, this is normal. You can see the Achilles tendon attaching to the heel, the calcaneus, and this is in a resting position. But then your affected foot, not only can you not see the Achilles tendon, which is a common physical finding, but the foot is in a different position. It's hyperdorsiflexed, and that's because these muscles right here, the gastrocnemius and soleus, they can't give that normal tonal plantar flexion to counterbalance the dorsal flexion that your anterior muscles are giving. So you'll be in it's almost as if those muscles were paralyzed, because they kind of are, because they can't work. They're just, rather than having paralysis, they are functionally paralyzed because they can't plantar flex the foot as they would do. Okay. So another thing that you can see on physical exam, of course, is a palpable gap over the Achilles tendon. So if you were feeling over this patient's right Achilles tendon, it would feel normal. If you were to feel over their left Achilles tendon, a lot of times you'd be able to feel the tendon, but then you'd appreciate a little gap where you can't feel the tendon anymore. And then as you move down inferiorly, you'd be able to feel the tendon again. So you may be able to feel a palpable gap. Another thing, in addition to the hyperdorsiflexion sign, is Thompson's sign. And what you do with Thompson's test, is if you were to hold this patient in this position, and what you want to do is you'd take the affected leg and you'd squeeze down on the calf muscles, on the gastrocnemius. And as you squeeze down, in a normal patient, you should get plantar flexion, because what you're doing is you're simulating contraction of those muscles. But if you don't get plantar flexion, that points you towards that the tendon is not working. And so if you're not getting passive plantar flexion while pressing on the calves, that's considered a positive Thompson sign, because it's an absence of passive plantar flexion of the affected leg when the calf muscles are squeezed. So the hyperdorsiflexion sign and Thompson sign are two physical exam signs that point you towards Achilles tendon rupture. But probably the most salient feature is going to be the palpable gap over the Achilles tendon and occasional swelling, as well as the history and the symptomology are very common and very obvious too. The diagnosis for Achilles tendon rupture is clinical. So for the USMLE, it's a clinical diagnosis. However, some clinicians like to use an ultrasound to see exactly where the rupture is, but you don't need to do that for the USMLE. The diagnosis is clinical. And the treatment depends on the expectations of the patient. So similar to like our MCL and LCL treatments, it depends on who the patient is. Is this just your typical weekend warrior who doesn't make their living off athletics, or is this an athlete who really wants to get back to competition as quickly as possible? It depends on the patient's expectations. For most patients, if they're not an athlete, casting is sufficient. But for an athlete, they may want to get surgical management, because surgical management does give you a faster recovery. But it's surgical and it's more expensive. So it really just depends on the expectations of the patient. For the broad population, casting is going to be sufficient. But for the athlete, it's probably going to be surgical management that you're heading towards. And then here's another Achilles tendon rupture. Picture is kind of bad here. Maybe you might be able to see which one is ruptured here. And it's this one here, the left one. And you can see maybe even a little bit of erythema there. So there's a left Achilles tendon rupture. Okay, fracture of the calcaneus. Now, I don't want to go into this in too great of detail, and the reason is because the management is not even agreed upon by orthopedic surgeons, so by no means are you ever going to be responsible for this on the USMLE or even probably even on surgical boards. I don't know, I'm not a surgeon though. But the cause of the fracture of the calcaneus, if you can imagine what the calcaneus is, where it is, it's your inferior most tarsal bone, and that bone takes on all of your weight. Each bone takes on half of your weight if you're standing in normal position, but it takes on all of your weight. So if you were to fall onto your feet from a height, not only are you taking on your weight, but you're also taking on gravity too. So falling on your feet from a height puts on a massive force on your calcaneus, and that can be enough to fracture the calcaneus. The calcaneus otherwise is an incredibly strong bone because it's constantly having force applied on it. Every time you're walking, every time you're standing, you're putting force on the calcaneus. So it's a very strong bone. But if you fall on to your feet from a height, that is enough force that it may cause a fracture. What do you see symptomatically? Well, in addition to the very obvious history, the symptoms are going to be pain on ambulation. Why? Well, you're walking on your calcaneus, on the bone that's fractured. And you may see a hematoma at the heel. And I'll show you a picture of that. The hematoma at the heel is when you have a history that's consistent with a possible calcaneal injury. The hematoma at the heel is really is pathognomonic for calcaneal fracture. For diagnosis, the best initial test is an X-ray, but CT is the gold standard. And the treatment, don't worry about it. So again, here's your calcaneus here, taking on all your weight. And here's that hematoma that you can see with a calcaneus fracture. Here's the fracture of the calcaneus. So even here, there may even be some comminution of this fracture, which wouldn't be surprising because you're putting on a massive direct pressure, which would be consistent with a comminuted fracture. And then here's another one, right here. Okay. All right, plantar fasciitis. So plantar fasciitis, first off, what do we need to know? We need to know about what the plantar fascia is. So the plantar fascia is just this fascial membrane that surrounds the ligaments that go to the toes, and it goes from the toes to the anterior inferior part of the calcaneus. So with plantar fasciitis, where it usually is injured is posteriorly, so at the insertion at the calcaneus. Now, how does this happen? How does the plantar fascia become stretched? Well, it becomes stretched when you flex your toes. And when you flex your toes, you are stretching the plantar fascia. And when you stretch the plantar fascia, you put stress onto it, and that stress can cause micro tears. And those tears can result in inflammation, and the inflammation then causes pain. And that would be plantar fasciitis, which is just medical speak for inflammation of the fascia. So excessive stretching of the plantar fascia. Other causes are possible. You're not responsible for those. Poor orthotic support with running, as well as low arched or high arched feet, may be seen in the history. So if you're running with really bad shoes, that puts you at risk for plantar fasciitis because you don't have that support of the arches of your foot. So you're going to have more stress on your plantar fascia while you're running. And then the low-arched or high-arched feet, just anatomically, you put more stress on the fascia to do your normal walking motion. And I'll show you a picture of what those look like. This is the 5th most common foot and ankle injury in athletes, so good one to know if you're working with a sports medicine population or with an older pediatric population that may be in sports. So the symptoms for plantar fasciitis is pretty distinct. It's a sharp heel pain, and it's on the anterior part of your calcaneus. So let's look at the bones again. Where are you going to feel this pain? You are going to feel plantar fasciitis pain right here. So it's going to be on the plantar aspect of your foot, but it'll be more towards the anterior portion of your heel. So it tends to be in this spot right here. Okay, I'll go back now. All right, so this sharp heel pain, and also another thing that's very typical of plantar fasciitis, not only where it is, but how it happens and when it happens. It notably occurs after long periods of rest. So a typical vignette for plantar fasciitis would be the patient is waking up, their first few steps in the morning are accompanied with severe heel pain. And it may get better after that, but then it can also get worse throughout the day. But the worst part is going to be those first few steps in the morning. On physical examination, you're not going to see anything visibly because this is just an inflammation of the fascia, which is quite deep. But what you will be able to note is a reproducible pain. And where are you going to be palpating? You're going to palpate right at where that pain is reported by the patient. So ask the patient to point to where the pain is at when they have it, and then press on it. I mean, I know that sounds kind of cruel, but this is a helpful diagnostic indicator. So the pain is usually reproducible with palpation of the affected site, the calcaneus, also on passive dorsiflexion of the toes. What do we want to differentiate out here? Some of the other things that can cause pain in the feet. So Morton's neuroma, we're going to talk about that next. Morton's neuroma is an inflammation of a common digital nerve in the foot, and Morton's neuroma, the pain will be reproducible with compression of the metatarsal heads. Also, Morton's neuroma tends to be more pain in the anterior part of the foot, whereas plantar fasciitis tends to be more in the posterior part of the foot. Achilles tendonitis, note here that this is not Achilles tendon rupture, this is just Achilles tendonitis, so inflammation around the Achilles tendon. That pain should be reproducible by palpating the Achilles tendon, whereas this pain in plantar fasciitis is more in the heel on the bottom of the foot. And then tarsal tunnel syndrome, which is pretty much the same as carpal tunnel syndrome, except for the fact that this is the tarsal tunnel rather than the carpal tunnel. And the tarsal tunnel syndrome, you should be able to reproduce the pain by percussing on right behind the medial malleolus. And what you're doing there is the exact same thing that you're doing with the carpal tunnel when you're percussing on the anterior wrist. So this is Tinel's test, and you're just percussing and you're trying to reproduce that pain. So hopefully you can differentiate these three pains out from plantar fasciitis. Diagnosis for plantar fasciitis is clinical. However, if you are asked what the most accurate test is, it's MRI. But I don't expect you to be asked that. Diagnosis is clinical. And the best initial therapy for plantar fasciitis is ice compress and rest. Rest is really the only way you can treat plantar fasciitis, and it usually takes about 4 to 12 weeks. You're also going to advise the patient to get better shoes with good orthotic support. Usually, if you could probably do a referral out to a podiatrist. They would be the best ones to know this. They'll be able to hook the patient up with the best shoes for plantar fasciitis. A lot of times you can go to pharmacies. They tell you what they've got special orthotic soles that you can put into your shoes that give you that support. But I would think that besides advising the patient that ice compressed and rest are the best initial therapy after you've diagnosed them, you may also refer them out to a podiatrist for further therapy that you wouldn't be able to provide. But for the USMLE, treatment is ice compress and rest. And there's your plantar fascia. Okay, and then this is, remember what I told you that a high arched or low arched foot puts you at risk for plantar fasciitis? This is a high arched foot, and this is a low arched foot. And these are just normal anatomic variants. So some people just naturally have this high arched foot. It's just how they were born. And some people just have this normally low arched foot. So the high arched foot is pes cavus, and that's this big high arch here. And then pes planus, which would be the flat foot. When I was going through my military physical, before I started medical school, I had on my little chart, they wrote pes planus, and I had no idea what that meant. So I went home and looked it up, and turns out my mom had always called me flat-footed my whole life, and turns out the doctor called me flat-footed too, just in Latin. Okay, so plantar fasciitis, running places stress on the plantar fascia during plantar flexion. That's what causes the plantar fasciitis. So you can see on this guy here, he's in plantar flexion, and so he's got a lot of force on his plantar fascia at the moment. So that can ultimately result in inflammation. Okay, so not to belabor that too much. Again, this is where your pain is going to be. Right about at the anterior part of the calcaneus. Okay, so Morton's neuroma. Morton's neuroma is a fibrosis and degeneration of a common digital nerve. Now remember, your common digital nerves, those are the nerves that split up and they give a branch to one toe and a lateral branch to one toe and a medial branch to the other toe. The common digital nerve is where Morton's neuroma happens, and usually it's going to be between the third and fourth digits. The female predisposition to this one is 5-1. Now, we don't really know why that is, but part of it may be because women tend to wear these high heels and tight-fitting shoes, and that not only may be a cause of Morton's neuroma, but it also commonly makes the symptoms worse. So when you talk to the patient, if she tells you that, oh, my high heels just make my foot pain so much worse, Morton's neuroma is something to think about. Because what are you doing when you're... first off, let me show you where the Morton's neuroma is. So Morton's neuroma is on this nerve right here, which is your common digital nerve, which then splits up to give a lateral branch to one side and a medial branch to the other. And the neuroma tends to happen right in between the metatarsal heads. And so when you compress the metatarsal heads together, if you were to squeeze this foot laterally or medially, you would be squeezing this neuroma, and that's going to cause pain. And when women wear high heels or tight-fitting shoes, they're sliding their toes in together. They're essentially squeezing their metatarsal heads together, and that's causing the pain. So that goes to our physical exam. On physical exam, a lot of times you can reproduce that pain by squeezing the metatarsal heads together or by compressing the metatarsals. Another thing that you can see here is numbness or dysthesias, and that's just because this is affecting the nerve. So for diagnosis, the most accurate test in diagnosis is the MRI, and that will diagnose the Morton's neuroma. That'll give you your definitive diagnosis. But most of the time, this is really obvious clinically. Just because if you compress the metatarsal heads, if you compress them, and that gives you pain, that really points towards this neuroma, just because of anatomically where it's at. The treatment for Morton's neuroma is orthotic support. There's really nothing we can do for it other than this conservative therapy. And in the very rare cases where conservative management fails, you may be able to do surgery, but it's not the preferred treatment. So the best test or the best treatment for Morton's neuroma is orthotic support. And what you're doing, and that kind of goes back to what the cause is probably, which is poor orthotic support, bad shoes. And what you're doing by having better orthotic support is you're separating these metatarsal heads so it allows for some healing of this neuroma. I will add that the Morton's neuroma is not a true neuroma. It's not a histologic neuroma, but it does have that name. So the Morton's neuroma is on your differential of foot pain along with plantar fasciitis, but just remember that the Morton's neuroma is more anteriorly, and it is reproducible by compression of the heads, the tarsal heads, and plantar fasciitis is more posterior pain, more at the anterior part of the calcaneus. So you can differentiate the two that way. And that's it. If you have any questions, let me know.